Hi, a very good evening to you all. Uh, Today we are on day 3 of this series of lectures on critical appraisal of medical literature. I am Dr. Sayan Das, a radiation oncologist from Kolkata. Today we are going to discuss very important topics. We had a primer last week from Dr. Indrain Malik about how to interpret the results of randomized control trials with an emphasis on superiority design. Today we have with us Dr. Santam Chakraborty, senior radiation oncologist from Tata Medical Center, Kolkata, and he'll be talking on how to interpret results of clinical trials with an emphasis on non-inferiority or equivalence design. Dr. Santam, please.
Hi, good evening to everybody. I hope I'm audible clearly.
Yes, sir, you are.
Thank you. So, as Sayan mentioned, we had an excellent talk last week where we learned how to critically appraise literature which deals with randomized controlled trials with primary superiority endpoints. And just for the audience sake, I would like to recapitulate. The steps would be checking the hypothesis. If you think that the hypothesis which has been formulated in the study is correct or not. Check the interventions that have been performed, particularly when you have studies which deal with trials which incorporate multimodality treatment. It is extremely important that the interventions that have been done, especially in the control arm, are standard and have been performed in the correct sequence and correct manner. The next step of evaluation lies in checking the endpoints, that is, whether the primary endpoints and secondary endpoints are the correct choice, whether these are surrogate endpoints, for example, whether these are endpoints like response, disease-free survival, relapse-free survival, or these are hard endpoints like overall survival, which actually make a difference to the patient. There is also the issue of composite endpoints, where several event types are enrolled or enmeshed into a single endpoint. And finally, whether the analysis is done as an intention to treat analysis. After you have evaluated these aspects, you take a look at the study population and decide whether the results can be considered representative enough for utilization in your own study population. Now, this is the basic template whenever any major study is being evaluated. Whenever you are evaluating the results of any study, whether it is a randomized control trial or not. Today, I will be speaking on non-inferiority trials because they have certain very specific features which need attention to when you are deciding to use this literature for your practice. Now, before we go to this, let us recapitulate a very important term, 95% confidence interval. Now, here I have presented two interpretations of 95% confidence interval. One, that is, if we repeat the experiment multiple times, the true population hazard ratio will fall between the confidence intervals 95% of the time. And number two, if we repeat the experiment multiple times, 95% of the confidence intervals will contain the true population hazard ratio. Now, on the face of it, it sounds as if these two interpretations are same, but they are not actually the same. So I would like you to take a while to think about this. And the reason I put this up is because interpretation of the 95% confidence interval is actually critical when it comes to understanding the results of a non-inferiority trial. Now, interpretation number one is wrong because the true population hazard ratio, for example, is a single value which will be within the 95% confidence intervals with 100% certainty at the same location. So what this means is that in this box, you can see that the true population hazard ratio is on this horizontal line. So it will lie over here only. It will not change its location based upon your width of the 95% confidence intervals. What, however, happens is that if you repeat this experiment multiple number of times, 95 of these experiments, the 95% confidence interval will contain this value of the true population hazard ratio. Now, what this means is that the confidence interval that you see in a non-inferiority trial may not contain the true population hazard ratio, and what you are getting from this 95% confidence interval is then estimate of the precision. Now, because the true population hazard ratio is always going to be unknown, because you are never going to be able to do this study in the entire population except in very few specific cases, you have to remember that this unknown hazard ratio will be something that we will interpret based upon one or two randomized trials. There is also another component that comes in when you are interpreting 95% confidence interval. How frequently do you think the point estimate of the hazard ratio for this trial will lie in the subsequent trials within the 95% confidence interval? The answer is not 95% as it may seem intuitively. It is often closer to 83% in the best case scenario. That means out of the 100 experiments that if we repeat, 83 of them will actually have this estimate, the first trials estimate, within their 95% confidence intervals. So understanding this limitation of 95% confidence intervals, let us now see and understand what non-inferiority and equivalence trials are. So non-inferiority trials are trials which are designed to test the efficacy of a given intervention against an active comparator. Now, this is a very important word, active comparator, which is why I have outlined it. Please remember that non-inferiority trials are never conducted against a placebo, unlike superiority trials, which may be conducted against placebo. And that's why non-inferiority trials and equivalence trials are having certain specific aspects which need to be understood. Now, the operational term non-inferiority implies that we are not expecting the intervention to be superior to the active comparator. And this is an important point to understand. The expectation of the investigator when you are doing a non-inferiority trial is that your intervention is not going to be superior to active comparator, which means you will only do these trials when there are specific considerations at hand. The null hypothesis which underlies this study is that the test intervention is inferior to that of the active comparator. And this is something that you would actually found misstated in many studies. For example, the HROC study, which evaluated the 6-month trastuzumab against 12-month trastuzumab, had made this mistake of stating that the null hypothesis is that the test intervention is not inferior to that of the active comparator. Now, you must remember in a superiority trial, our null hypothesis is that the test intervention is the same as that of the active comparator. Here, the null hypothesis is in the opposite direction. What it implies is that the power of the study actually is important in the non-inferiority trials. What are equivalence trials? Equivalence trials are an extension. Here we are testing two hypotheses simultaneously. First, the active intervention is non-inferior to the active comparator, and at the same time it is also non-superior to the active comparator, which means it must have an effect which lies within a narrow band. As per the ICH 1998 definition, two interventions do not differ in either direction by more than a pre-specified unimportant or insignificant amount. That means here you are implicitly doing a two-sided test, whereas in case of a non-inferiority trial, you are doing a one-sided test. So what this implies is that equivalence trials are of limited utility in most clinical scenarios when you are doing clinical trials. However, they assume extreme importance when you are testing new drugs, where you want the drug to have the same efficacy as the previous or patented drug. So that's why equivalence trials are often conducted in the setting of bioactivity and bioequivalence studies. And to illustrate this in a graphical manner, suppose that the solid line, green line, is the line of no difference. There are several studies which have been performed. Each of them have an estimate, which is the effect size, typically hazard ratios for most clinical trials, and there are 95% confidence intervals associated with that. You have a predetermined threshold of inferiority, and we will discuss how this threshold is set. There is a predetermined threshold of superiority. Whenever a study is done in this manner, the interventions which are considered equivalent will be this, and this. That is, these three interventions would be considered as equivalent. These will be considered as inferior. Reason is their 95% confidence intervals actually crosses the line of threshold. These interventions will not be considered as equivalent because they are actually superior. Now you must remember, superior doesn't necessarily mean better. Superior is a relative term. For example, when you're doing bioequivalence studies, you really don't want the drug to have a greater potency or efficacy because all the phase 1 and phase 2 as well as the phase 3 trials have been done with a specific dosage in mind. So when is a non-inferiority design appropriate? And this is the first question that you must ask yourself when you are designing studies or evaluating studies with a non-inferiority design. For drug development trials, these are usually ethical considerations at play, where disease is such that placebo control is not acceptable. It is also useful when you have studies where you want to assess the intervention of cost effectiveness. For example, a common example where we treatments with employing lesser fractions of radiotherapy, fewer cycles of chemotherapy, etc. When you want to compare therapies which can potentially give you a better quality of life and toxicity profile while maintaining the same efficacy. So, for example, a more conformal approach of therapy. Now, this is a very, very important thing to understand that often the correct design is not used for practical reasons. If you evaluate a conformal therapy properly, you will understand that most conformal therapy trials which have been performed till date have not employed an element of dose escalation. As a result, technically speaking, you cannot have an better efficacy in these trials in the terms of better tumor control. What you can expect is a reduction in toxicity. So that is where non-inferiority designs come into play. And finally, to compare therapies which are easier to deliver and take, for example, trials where you are taking, say, for example, an oral mode of therapy instead of an intravenous mode of therapy, and so on. Now, the issue with non-inferiority trial and why it is very, very important to evaluate non-inferiority trials stringently is biocreep. Now, what is biocreep? Let us understand this. Suppose you have a scenario where this solid line is basically the zero effect line, which means the line where you consider that the intervention, the experimental intervention will be same as your control intervention. And this is the first trial that you obtain. This is the first non-inferiority bound. You can see that this intervention is actually non-inferior. Once this intervention becomes non-inferior, technically, this intervention can then serve as the control for the second trial of a newer intervention. This happens in the second study. Again, this intervention is non-inferior to the first intervention. The second intervention now becomes the control. Another non-inferiority trial is done. And this is the third one. Now you can see that it has actually moved away so much that actually the effect estimate is beyond the line of non-inferiority. And by the fourth setting, the 95% confidence interval, the lower bound of the 95% confidence interval of the effect is lower than that of the original trial. One thing you have to understand that poorly designed non-inferiority studies are biased towards non-inferiority. And that's why this phenomena is extremely insidious and difficult to pick up. It is also important to remember that in modern era where multimodality therapy is being considered and therapy de-escalation seems to be in vogue, successive non-inferiority trials employing successive therapy de-escalations may all have elements of de-escalated treatments which are not specified in the protocol. So, for example, you may have studies where instead of doing axillary nodal dissection, you do sentinel lymph node biopsy for node positive axilla. You do not end up treating the axilla with radiotherapy. You end up omitting the chemotherapy for these patients. Now, because non-inferiority studies are done in settings where there is a good efficacy, which means for most scenarios where non-inferiority studies would be done are disease settings where we already have good outcomes. What happens as a consequence is that successively the trials actually lose the benefit that we have won so hardly. And this is one of the concerns when de escalation studies are being done. And you have to interpret these de escalation studies very carefully. The second most important thing that you must assess in a non inferiority study is the non inferiority margin. Now, what is the non-inferiority margin? It is an acceptable difference between the test arm efficacy and the control arm efficacy, at which threshold you would consider this to be clinically unimportant. Please remember, non-inferiority margins are not designed keeping in mind statistical significance. They are always designed keeping in mind clinical efficacy. And this is one of the most critical things you must assess when you are reading a paper with a non-inferiority trial design. The design is done in such a manner that the upper bound of the 95% confidence interval for the effect estimate is never more than this margin. What does this mean? Going back to the previous image, this is the effect estimate, say the hazard ratio. This is the lower bound of the 95% confidence interval, and this is the upper bound. Why do we call this the upper bound? Is because this is the zero effect. On the left side, typically the hazard ratio increases because this side shows that the control is better. This side, the hazard ratio is actually lower. So this is why this is called as the upper bound. So these are the scenarios where we can have, for example, this solid line is again the zero effect line, and M indicates the non-inferiority margin. After the trial is done, in order to claim non-inferiority, the upper bound of the 95% confidence interval, which means this bound, must lie within this dotted interval. If it is not, you have failed to prove non-inferiority. Now, here I have marked them as inferior. It doesn't mean that they are inferior. Statistically, inferiority will be proven only if the hazard ratio is such that it does not cross this line of zero control. For example, here and here. This is uncertain. Although it has not met the non-inferiority criteria, it may not be inferior. These two trials are non-inferior, which means they have proven their endpoint. And this one, because the upper bound of the 95% confidence interval you can see is not crossing the zero line, is actually both non-inferior and superior. One, sometimes what may happen is that you may have a trial which is both non-inferior and inferior statistical. Sounds very strange. What happens is that suppose you have 95% confidence interval lying completely on this zone, It is not crossing the zone of zero. It is definitely non-inferior based upon your definition, but it is also inferior because the other bound of the 95% confidence interval does not cross zero. So this is the important reason why you must evaluate this plot. In many situations, you will not get a plot like this. You will get a Kaplan-Meier curve with an effect estimate. You basically have to read the paper to understand what their non-inferiority margin was, and based on that take a call whether the study proved non-inferiority or not. Now, why is a non-inferiority margin important? If you have understood the previous slide about biocreep, you would immediately come to know why it is so important. A non-inferiority trial, as I mentioned, cannot have a placebo control. So therefore, you cannot determine the actual effectiveness of the control arm. What do I mean by this? Suppose you had a non-inferiority trial where you had a placebo, you could actually find out how much effective a control arm truly is. And you can then determine how much of this efficacy is lost by the experimental arm. Now, unfortunately, this is not ethical, and as a result of which, we will always have non-inferiority trials with an active control. Now, because of this, the benefit that we are proposing for the active control is extrapolated from previous studies, expert knowledge, or as an guesstimate. And therefore, it is important the magnitude of this benefit or the magnitude of the non-inferiority margin is not the same as the benefit that you get from the placebo. What does that mean? Suppose this is the benefit that you get from your study when you did the trial over the placebo. The dashed line is the effect of the placebo, solid line is the effect of your active control. This is the magnitude of benefit you get. You cannot have a non-inferiority trial designed such that the non-inferiority margin is this wide, because in that situation what will happen is some of these studies may have a situation where the experimental arm is actually worse than the placebo, which is shown here in this asterisk. So an adequate portion of the clinical benefit from the control should be retained. Now, unfortunately, this is not something that is immediately written in the manuscript. Oftentimes, this would be placed in the protocol in a small paragraph, primarily because of word limit issues. But this is a very, very important consideration to keep in mind. The non-inferiority margin should ideally never be more than half of the benefit that you get from the placebo. And let us take an example of a very, very important study which has recently come, the Target A study, which has presented their long-term outcomes. And I would read and quote the non-inferiority statement they had used. In the original protocol, non-inferiority was specified as being achieved if the difference in the binomial proportions basically means the proportions, of local recurrence rate at 5 years did not cause a stringent margin of 2.5% in absolute terms. Now, in the next slide, you will understand what is the problem with this statement, but let us go from here. That is the local recurrence risk with the target IORT minus local recurrence risk of EBRT should be no more than 0.025, that is 2.5%. What they found in the intention to treat analysis is that in the IORT arm, the 5-year local recurrence rate was 2.11% versus 0.95% in the EBRT arm. The difference was 1.16. The 95% confidence intervals were between 2.16 and 0.15. And they claimed that target A is non-inferior. As a clinician, you must always remember that when you are talking about such low local recurrences, your first question should be whether this intervention is at all necessary or not. And we have trials to prove whether this is necessary or not. So, for example, the PRIME trial, which investigated the addition of whole breast radiotherapy versus no treatment or no radiation. That showed at 5 years a local recurrence rate of 4.1% versus 1.3%. The PRIME trial was actually did not meet its primary endpoint, and the difference is 2.8%. Now, if you go back to my previous slide and understand what has happened, this is the upper bound of the 95% confidence interval, 2.16. It is nearly the same as 2.18. Effectively, it is very difficult to conclude that target A may be no better than no treatment at all. Target A, IORT, lost nearly half of the benefit of non-treatment, if not more. So this is a very, very important thing that you must understand. Unfortunately, this is often not specified in the manuscript as it should be, although there is some effort going on towards making sure that this is correctly specified. And this is a study which is relatively recent, 3 years ago, where they reviewed the literature and tried to find out what was the method adopted for defining the non-inferiority margin. You would imagine that for such important studies where you can potentially lose efficacy, people would be very careful in defining non-inferiority margins. Unfortunately, vast majority of the studies, non-inferiority margins are based upon expert opinion. That's level 5 evidence. Very, very few have actually used proper literature review and meta-analysis to obtain this margin. Some studies have used the same margin which is used in the previous trial, which may have been obtained from expert opinion. So effectively, even now, even till date, there are very, very few studies which have actually using non-inferiority margins which are defined in a scientific manner. Next comes is how should this non-inferiority margin be specified? Should it be specified in terms of an absolute risk difference or relative risk difference? Now, when you are evaluating scientific paper, the absolute risk difference actually is a very important thing for you to understand because it quantifies the benefit or harm that you have from the study. So, for example, if you use a superiority study, you must understand that relative risk or relative benefit that you get from an intervention may misinterpret the actual magnitude of benefit. In case of non-inferiority trials, on the other hand, proposing absolute risk difference as the non-inferiority margin is actually not recommended. So, the absolute risk difference is problematic because it does not depend upon the control rate. So, most of the studies, for example, even the target study, which specified this 2.5% difference, did not specify how much the control rate should be for it to be considered as 2.5%. 2.5% over a 10% local recurrence rate is probably acceptable, but 2.5% over a 1% local recurrence rate indicates that you are expecting or accepting nearly 2.5 times higher risk of recurrence. So, the protocol specified control rate of 90% with an absolute non-inferiority margin of 3%, that is 87%, may be acceptable, that is a relative risk of 1.3. Actual result control rate of 95%, instead of 90%, suppose your control rate was 95%, and your experimental rate was 92%, means your non-inferiority margin is 1.6. So you can understand that when you use absolute risk differences to define your non-inferiority margins, you bias your trials towards non-inferiority. Because classically what happens is, as time progresses, outcomes tend to improve in cancer. And you will see in most of the settings, we often tend to have control arms which perform better than expected. The recommendation, therefore, from various organizations is to use relative risk difference measures like hazard ratios or relative risk. And if the absolute risk difference has been used in the protocol, like for example in target A, it is extremely important to go back and check what their proposed control rate event was. If it is lower than what is observed in the trial, your non-inferiority margin may not be correct. And just to highlight this point a little bit better, this is a graphical relationship of what happens as to the relationship between absolute and relative risk. So this is basically a control arm where there is a 5% failure rate. A 2% difference from this, or 2% increase, means nearly a 30-40% relative risk. A 10% means a 200% relative risk. Sorry, 200% relative risk. On the other hand, when you have got a control arm with a 20% failure rate, you can see that the relative risk change is much lower. As I mentioned, for vast majority of non-inferiority trials, actually is done in settings where we have good cancer control. So this is usually the norm. So that is why it is extremely important to see the absolute or relative risk difference has been used in defining the non-inferiority margin. The next thing that you have to see is whether this non-inferiority margin has been proposed for a single endpoint or a composite endpoint. I'm not going to talk about surrogate endpoints that has been dealt in details by Dr. Malik, but composite endpoints are a problematic issue when you are doing non-inferiority trials. The reason is that all events in the endpoints may not behave in the same manner. And what is composite endpoint? For example, disease-free survival. It includes events like disease recurrence, deaths, second primaries, and so on. Now, you may have an intervention which reduces disease recurrence but increases second primary. The composite endpoint will actually mask this. Especially composite endpoints which do not have a clinical impact make it easier to demonstrate non-inferiority. Another term that you would commonly come across is assay sensitivity. Now, it seems like I'm going into biochemistry, but bear with me. Assay sensitivity in terms of trial design is the ability of a trial to distinguish an effective treatment from an ineffective one. In case of superiority trial, when you have proven superiority, you have also demonstrated effectiveness, right? Because a superiority trial will be done against an established treatment or a placebo. Whatever but the result, if your trial is superior, it indicates it is also more effective. In other words, your trial has assay sensitivity. In case of a non-inferiority trial, the experimental treatment is actually non-inferior and therefore we cannot claim that it is effective. Why? Because your non-inferiority trial, the experimental treatment, may be non-inferior but not effective if you have chosen a particularly wide non-inferiority margin. Hence, to determine assay sensitivity or the effectiveness of the experimental treatment, it is extremely important that you review the available evidence for the effectiveness of the control as well as understand whether the non-inferiority margin has been chosen correctly. In addition to this, the way the trial has been conducted is a very, very important determinant. Now, if you have poor compliance with therapy, say for example, your patients did not take the treatment properly for various reasons. It may be more expensive, it may be more toxic, people may not have had the motivation to go through your lengthy treatment. Whatever happens, whenever you have got a poor compliance, you lose power. Now remember, because the non-inferiority hypothesis is posed in such a manner that the null hypothesis is actually that the experimental is inferior to the control, power makes a difference. If you have a loss of power in the trial, you end up proving non-inferiority. Poor responsiveness of the participants to the therapy, use of concomitant non-protocol medications in a different manner, populations with better prognosis or where the prognosis improves spontaneously, and bias arising out of blinding in assessment of endpoints are other reasons why assay sensitivity may be lost. The bias arising out of lack of blinding is extremely important when you are dealing with non-inferiority trials where a clinician reported outcome is being taken as the primary endpoint. Say, for example, fibrosis or lack of cosmesis, and so on. What happens in these situations is that because your physician is not blinded to the intervention, he may end up proving that the intervention which you are proposing is actually non inferior to the control when it truly is not. This is a problem which happens in superiority trial also, but non inferiority trial, as I mentioned, because they are so dependent upon your power and therefore assay sensitivity is affected by power, these biases creep in and play an even more important role. Finally, to conclude whether the results are valid or not, you have to first determine whether the effect of the standard treatment has been preserved. Of course, you must look at the non inferiority margin and the justification, as I mentioned again and again, but you must also compare the results of the active control to that of the published literature. So, where you have situations where your control arm performed much poorly than what was expected from the published literature, or where it was not delivered appropriately, or where there was a lot of drop off, you can rest assured that your non inferiority trial is probably not reliable. One thing very important, and once more I will highlight this point, at least 50% of the effect of the active comparator against the placebo should be retained when the non-inferiority margin is decided. And oftentimes this judgment has to be made by you because it is not explicitly mentioned in the protocol. Finally, is a per protocol analysis present? As we mentioned previously, an intention to treat analysis is extremely important because it removes the bias that, or it removes the chance of the bias which happens after randomization. A per protocol analysis is extremely important in a non-inferiority trial. Results of the per protocol analysis should match with the intention to treat analysis because of assay sensitivity depends upon how the trial interventions have been given. Coming to the question whether you can apply these results in your population or not, the first thing you have to understand is whether this is a superiority trial which is being passed off as a non-inferiority trial. This is not so uncommon as it seems. Oftentimes, and I will give a very famous trial example, that is the chart trial in head neck cancer. It was designed as a superiority trial when the superiority endpoint was not met. The conclusion was written that it resulted in the same local control. Now you have to remember that a superiority trial cannot be used to establish non-inferiority because by design you have not specified a non-inferiority boundary. Going back, when do you say a trial is superior? You claim a trial is superior when this scenario happens. That is, the estimate is definitely above zero, your lower bound as well as the upper bound are above the zero. You do not meet this condition when you have this, right? When one bound of your 95% confidence interval crosses the line of zero. But you really don't know whether it is this crossing the line of non-inferiority also. It may so happen that this dashed line is actually over here. The trial shows, therefore, you cannot claim that your intervention is non-inferior when you have done a superiority trial unless and until you have pre-specified it in the protocol and made sure that you take care of this in the analysis itself. The next important consideration has to be paid is whether the study patients are similar to your patients. This is extremely important when you are doing non-inferiority trials. Why? As I mentioned, the vast majority of the non-inferiority trials will show you an hazard ratio, say an hazard ratio of 1.2. So a hazard ratio of 1.2 means that your 95% confidence interval upper bound may be 1.2, means you can have a 20% excess risk of recurrence. Now, please remember that this is a relative risk and therefore it depends upon what your baseline risk is. Suppose your study population has a lower baseline risk of the event as compared to your population, you may have a much higher absolute difference as compared to what the study expected. That's why it is important to carefully evaluate. Were the outcomes clinically important for your patients? This is a very important question that you must answer. Trials which rely upon surrogate endpoints, composite endpoints, are something that you must be carefully evaluating. And finally, are the likely advantages of the treatment worth the harm and cost? This is something very healthcare system dependent. For example, you may have an intervention which has been done said as cost effective in USA, where vast majority of the cost is borne by insurance. On the other hand, where you are working, you may not have this problem because the patient is paying for the intervention. There is no insurance here. And the real benefit in terms of logistics is probably minuscule. There is no reason for you to adopt that non-inferiority trial unless it shows a difference in quality of life or toxicity. So, coming to my conclusions, non-inferiority trials need extremely close scrutiny. Unlike superiority trial, you will need to pay attention to the margin of non-inferiority, the width of the 95% confidence intervals, the conduct of the study, availability of a per protocol analysis, and unless it is more cost effective, less toxic, or better quality of life, a non-inferiority trial may not have generalizability. Thank you, and like to thank my team members in my department and this beautiful hospital where I work in for giving me the time to present this presentation.
Thanks a lot, Santamda, for this beautiful deliberation uh, regarding how to understand uh, non-inferiority results of non-inferiority design trials. Uh, Time for the QA session because Professor Tannock is, I think, yet to join us. Uh, Santamda, can you check the
Yeah,
chat box?
yes, I can check the chat box.
Okay.
I think Dr. Vishnu has asked a question as if an inferiority trial has already proven hyperfractionation to be non-inferior to conventional fractionation, and we want to prove a new extreme hyperfractionation to be non-inferior. In this scenario, would it be statistically better to compare it with the initial conventional fractionation, or is it enough to compare it with the hyperfractionation schedule? Now, one thing very important to understand is that there is no question of a statistically better. You do clinical trials for clinical efficacy. And clinically, it makes much more sense to compare it against the conventional fractionation if it is the standard of care. On the other hand, this is something that I imagine is being asked in relation to the breast cancer studies. It is not a single hyperfractionation trial which has shown non-inferiority. There are several well-designed non-inferiority trials in breast cancer which have shown non-inferiority, and therefore hypofractionation has been accepted as the standard of care. In such a situation, it makes no sense to compare it against initial conventional fractionation. On the other hand, if this was not the case, where you had a single hypofractionation trial, it would probably be better to compare it against the conventional fractionation unless and until you had a situation where the hypofractionation arm was not only non-inferior but also superior. Does that make sense?
Yes, I believe. So,
Shouldn't there be superiority margin as well as to say it is superior, or just crossing zero would be enough with reference to slide number 9? Yes, statistically just causing zero is considered enough. However, if you want to pre-specify a superiority margin, it is perfectly acceptable to do so in the statistical analysis plan.
Shantam, Shantanu here.
Yeah, Shantanu, tell me.
Yeah, I would like to discuss that, permitting time, permitting Dr. Sayan Das, and I would also like
yeah.
to comment on something.
Yes, please.
So the comment first, uh, I'll in chat the chat box. I'll write the comment and I'll also give a link for this. You have it's a technical comment. What the comment is does not detract from the entire presentation, which is absolutely excellent. And I just want to sort of, for the record, make it straight that the H naught for an inferiority trial is not about inferiority. It's actually inferiority or equal to. And that's even the FDA guidance,
Yes.
that the T minus C should be less than or equal to 0,
Yes, I
which
agree.
actually, thank you, which actually leads me to your slide regarding the superiority and the point which you just now mentioned, as well as your slide which says how to apply this. I would sort of differ. I'm not saying I'll disagree, but I would say I would differ, because if we are talking of trials of efficacy versus trials of effectiveness, and the effectiveness can be cost effectiveness, it can be clinical effectiveness. For example, if we want to do let's say a cluster randomized trial for effectiveness, clinical effectiveness, non-inferior trial, if suppose we want to do that, in that case, I would consider that just crossing 0 would not necessarily, even though it might be statistically significant, but it not necessarily would be clinically significant, because nobody has defined what the clinical superiority margin should be. So
Absolutely agree,
I'm not
Shantanu. It
disagreeing
is a
with you.
statistical superiority. I mentioned that clearly. It is
Yeah, I'm not
statistical
disagreeing with you.
superiority. Yeah. It
But
is
but
not clinical superiority.
where I would differ from you is in that particular slide which you showed, where you say very clearly it's superior. I would not necessarily agree with that. It would depend on what kind of superiority we're talking about.
Yes, I agree with you,
But
Shantanu.
thank you so much. I mean, thank you for allowing me the comments, and excellent presentation.
Thank you, Shantanu.
So, are there any more questions? Uh, Shantana, would you like to discuss about the utility of blinding in non-inferiority design? It is important for
Yes, actually,
superiority.
it is also very important for blinding. As I mentioned, what happens is that when you are doing non-inferiority trials, why do you do it? You do it for things like cost effectiveness. Commonly, you do it for toxicity. You do it for quality of life, right?
Yes.
Now, what you must remember is that in the vast majority of settings where we do non-inferiority trials, say for example, you take the example of the fast forward trial, right? How many grade 2 plus events were there? Less than 10%. A very small number, right?
Yes.
So what happens is that it is very, very easy to prove non-inferiority. Means you just need to have one or two biased investigators and you will get non-inferiority. Are you understanding what I'm saying?
Yes. Yes. I get it.
So that's why blinding assumes a great amount of importance when you're doing non-inferiority. Unfortunately, uh, scientifically, logistically, or economically, it is often not feasible. But if you can, it is probably better. Means scientifically, blinding is always better in terms of outcome assessment, particularly when you are dealing with outcome assessments which are being done by clinicians.
Uh, may I make another point here, Santam and Dr. Sayan?
Yes, please.
Is it okay, Santam?
Yes, please go ahead, Shantanu.
Thank you. I nothing again nothing against what you have said. Absolutely, I'm just continuing your point further. Differences between randomization and versus blinding and minimization. Like the French are pretty fond of using minimization. I would look very carefully at the concealment of allocation or equivalent in a minimization strategy trial rather than a randomization strategy trial, as opposed to as opposed to a randomization strategy, because in minimization strategy you are not truly technically randomizing, so the bias creeps in even more. And I would probably not do a non-inferiority trial with a minimized design. What do you say about that, Santam?
Yeah, if you have a situation like this, I agree with your point, Shantanu. But randomization per se, randomization, allocation, concealment is definitely important. If you have a sufficiently large sample size, actually the way you have done the randomization probably makes little difference.
No, I'm saying minimization, not randomization. Like
Minimization for what?
there's a strategy of randomization, true randomization. Then there's a minimization strategy, which
Yes.
usually the French use. So I would
So
not.
minimization strategies are basically ensure that you do not have money. Money. You have to have a certain number of group, money people in a certain number of group. If I'm not incorrect, what do you say,
and
Shah?
and the ethical thing is about that people can actually choose to understand and leave before or after minimization, which is a problem, because that then reduces the power a hell lot. So I would probably not do a minimization strategy for a non-inferior trial, because then that might result in more than, let's say, 5% dropout or crossover, and then change the power drastically.
Yeah, that of course is definitely there. If you
Yeah.
have situations where patients leave your experimental arm or your control arm, you obviously have a bias, and that is what I mentioned, that you, whatever you have money in terms of your study, wherever you do not have adequate compliance and adequate assessment, you will land up in difficulties in concluding non-inferiority, especially if this assessment is being done with your primary endpoint in mind.
Yeah, I was just sort of furthering your point, nothing more than that. Just complementing your point with another point. That's all.
Absolutely, absolutely, Shantam.
Thank you.
So if anyone else has a burning question, feel free to unmute yourself and ask the question, because we're still waiting for Professor Tannock to join. His class is going to start from 8 o'clock.
Hello.
Yes.
Sorry, I came in a bit late. Can I ask a very basic question? I'm not a statistician, a very novice, and I heard a bit of your talk. Can you just tell me what would be the problem in a non-inferiority design? What should be the sample size? Because I missed the initial part of your. Sorry, if you have covered it.
No, no. Yeah. May I know your name? Is this
I'm
Dr. Dinesh?
Dr. Dinesh.
Yeah,
I'm
Dr.
in an
Dinesh.
MBR, Cancer Care
Yes,
Center,
yes, yes. Yes, I know.
California.
Yeah, I just wanted to confirm.
Yeah, I
So,
just
Dr. Dinesh, I
sorry,
haven't
I
taken
joined a
anything
bit
on
late.
sample size calculation at all. The
Pardon?
reason is that this is a, what do you call it?
Would it require
The
a
topic
larger
was,
sample size in a non-inferiority design? Would it
uh,
require entail a larger size to
the
complete?
sample size largest is not really based upon the non-inferiority design. It is based upon three things. First of all, the fact that when you are doing non-inferiority margins, you generally have to keep very stringent margins, so your difference or effect size becomes small. Secondly, you must have uh, one-sided testing, which means typically you would adopt a one-sided type 1 error of not 5% but typically 2.5%. And
Okay.
finally, you often would want to keep a greater power, as I mentioned in my talk, that unless and until you have sufficient power, and that's why several non-inferiority trials are done with power of 90% instead of the usual
Okay.
80%. So if you have these considerations, that is the reason why non-inferiority trials often have a larger sample size.
Okay.
That
Okay.
said, superiority trials also can have the same thing, and means, but usually what happens is that for superiority trials we have, how should I put it? Our margins are much more wider. Means we typically wouldn't be looking for that much small difference in superiority unless you are
Okay.
privileged to conduct
Okay.
a pharma trial.
Okay. From the clinical point of view, randomized trials are very difficult, and we see a lot of literature coming up with this propensity score matched analysis. Is it something similar? Is it possible in a non-inferiority design or something which can override this? Is there any way to?
Unfortunately not. Unfortunately not.
Unfortunately.
This is something you must remember, that any propensity score based analysis relies on your knowledge of the factors that you are going
Okay.
to match, right? You cannot have a factor which you do not know and you're matching for it.
Correct. Yeah.
Now, randomization, the biggest strength of randomization is that it removes unknown factor bias.
Okay,
So
but
if I
still,
explain this a little bit better, maybe it will be easier to understand.
okay,
Around 20 years ago, we were not really aware of human papillomavirus associated oropharyngeal cancers and the impact that had on the outcomes. Now,
okay,
suppose you're doing a propensity score based analysis of patients, say, treated with a typical non HPV associated malignancy versus a non HPV associated malignancy at that time. You would not really match for HPV, which is probably the most important fact. And as a result, what will happen is that you will conclude superiority of things like using IMRT, using cetuximab with cisplatin and things like that. It's only when you do a randomized control trial that you will be balancing out the unknown factor. And that's why to conclude true non-inferiority, and you must remember that the bar for assessing a study or conducting a study when you are doing non-inferiority is much, much higher than when you are doing superiority. Because with a non-inferiority trial, you run the real risk of actually coming up with a treatment which harms the patient.
but still there are a lot of people who actually argue against RCT, and they say that still it's not the correct way. The Bayesian model would be better. But
These
I'm not
models
very
are not
cognizant.
a substitute for randomized control trials.
Okay,
They help in getting more certainty from your results, but to a certain extent, it depends upon hype. It is not really driven by science; it's more driven by hype and the fact that you have a tenure that you need to complete, and you have an X to grind and things like that. That's what I would say. Scientifically speaking, till now, I don't believe any statistical method can do what randomization can. And that is something that is going to continue in the future just because of the way chance plays out.
do you think the way we randomize also matters, and is there a best way of to do it?
Yeah, as Shantanu and myself were discussing, if you use a minimization technique, then probably it is not a good way to go ahead with for non-inferiority trials. That said, for most large non-inferiority trials, unless and until you have cohorts which have very different prognosis and which are uh, you know uh, accounting for a small number of your or sample of the population, your simple randomization often can do the trick actually. You But typically most people would want to have a sort of stratification inbuilt in the randomization.
Santam, can I add or address
Yes,
the
yes,
previous
Shantanu, you
question
don't need
also?
to ask for my permission. Please go
No,
ahead.
you are the
I
person
am
named
not.
by
Sayan
and
is.
okay, doctor, I would like to sort of address your previous question regarding the ethicality of why it's considered so-called unethical to conduct a randomized trial. It's actually got the basic problem or the ethical concern with the randomized trial is that is it ethically correct to subject a patient to something which may or may not turn out to be a standard of care?
Correct.
Now, there are two aspects which, again, ethical people look at, ethicists look at. And the first is that you should always allow the patient inducted in any arm to cross over or be dropped and given standard of care. So that is part and parcel of, in general, it's supposed to be an ideal consent form where you state outright that if you don't want to participate, this is more true for non-blinded studies because people may know that they are not going to get the standard of care and they're going to get the test arm. And the second issue is that many people unfortunately conduct randomized trials when the standard of ethical care is not correct. Now, what is that standard of ethical care? The standard of ethical care is true equipoise or clinical equipoise should exist, which means that whatever the literature is saying, if you're comparing A with B, then A and B in the given this complete literature which exists till date, till the time the randomized trial is supposed to be started, before that, A and B should be considered clinically equivalent. If true clinical equipoise is not met, then you cannot really ethically conduct a randomized trial. Now,
Correct.
that being said, there are that being said, there are trials, as I was saying, of efficacy, where you compare with the placebo, and trials of effectiveness or effectiveness. Yes. So when you compare two standards of care, you cannot really conduct a randomized trial of superiority, assuming that the true trials are those two standards of care are really standards of care, parallel standards of care. Then it's better to probably go for either an equivalence or perhaps a non-inferiority study. But then your endpoint probably will not be efficacy related. It'll probably toxicity or cost effectiveness. So it's difficult to it is not difficult to ethically justify randomized trials if they are conducted in the right context, in my opinion.
Correct. That's a valid point. Equipoise is a valid point. I think we missed a lot of
Uh,
this during the pandemic.
yeah, I think I need to just cut you short because we need to start our next session.
Yes.
Thank you.
Sorry.
Yeah, and for this we have an esteemed faculty with us to discuss this. We have with us Professor Ian Tannock. He'll be discussing regarding the misleading presentations of clinical trial results. Professor Tannock is, as we all know, is kind of a living legend. He's a professor emeritus in the Department of Medicine and Medical Biophysics at Princess Margaret Cancer Center and University of Toronto. Uh, just a few words because I first uh, listened to his lecture, I think in 2016 or 17, at the Platinum Jubilee celebrations at Tata Memorial Hospital in Mumbai. And it was an eye opener for me because once he went back home, I started reading his articles, and he has got phenomenal work in metastatic prostate cancer, and he has been working for the several years regarding these issues about critical appraisal of medical literature, and we felt he's one of the faculties which we really want us to mentor on this topic, and we really honored that he readily agreed to take up this topic. So, Professor, please.
Thank you. Good morning, everybody. I can only see some of you. Most of you are blacked out, but I'm amazed that so many of you are actually attending something on a Saturday evening. I don't think in my country we get much of an audience on Saturday evening. So what I plan to do is to first talk to you for about 40 minutes, and then I've fairly randomly drawn some radiation trials that we could, if we have time, discuss. So hopefully that will work well. And of course, I'll be happy to take questions at the end. So let's do the technical bit. I'm going to try and share my screen, and hopefully we can go from there. So here's my screen. That's not what I want to show. I've got here, I had Can you see the screen?
No, sir. I mean, yes, we can, but we can't see your slides.
You can't see my slides. Okay, something here is not right. All right, let me escape and let's go back here. And I get it says I'm screen sharing, but it's not showing here on the. I've got Firefox post attendance, and I'm not quite sure how to do this. Let me stop sharing for a moment. I have up there. This is coming up differently. Here we go, I think.
Yes, sir.
Okay, I don't know what happened to the formatting. It's gone a bit wrong, but anyway, I think we can work with that. It looks as though it's modified it. So first of all, a slide that all investigators see, and you're all seeing the slides now, are you?
Yes, sir.
Yeah, okay. So in terms of conflict of interest, I don't think I have any. I think most of the pharmaceutical companies actually dislike what I say, right? So it's unlikely that I'll have any conflicts of interest. And I do not accept money from pharma or go to their satellite symposia. So in talking about clinical trials, there have been some very good practice-changing trials that have been published over the last while in various types of treatment. And two of them that involved radiotherapy, because I gather you're all radiation oncologists, the PROTECT-T trial, which compared surgery, radiotherapy, and watchful waiting for screen-detected prostate cancer, is an amazing trial to do, where you compare different modalities of treatment. And it showed that 10 years, that less than 2% of people with PSA detected prostate cancer actually die of their disease. Most, if they die of other things, and that there was no difference between surgery or radiotherapy, or in terms of death, watchful waiting, well, there was more progression. The STAMPEDE trial in prostate cancer that continuously adds new therapies. And I know Nick James came to the Tata last year, because I was also in Mumbai teaching in Credo. And he has led this trial, which has shown that various treatments improve survival, including radiotherapy, to the local disease for those with advanced prostate cancer. And then there have been various trials of immunotherapy, which have changed the treatment for melanoma, lung and kidney cancer, and others. So coming to the topic of today's talk, which is essentially how do you read clinical trials critically? Because there are many good trials like the ones that I have just talked to you about, but there are also many trials that are presented with all sorts of problems, and we need to be able to dissect the good trials from the ones that are not good, and also are being pushed particularly by pharmaceutical companies, where the aim, of course, is profit. Sometimes profit can be convergent with helping your patients, but that's not always the case. So a simple guide when you read the report of a trial in the literature, and I'm only going to talk about randomized clinical trials today, and I know your last session was on their ethics, and we can even touch on that. But the questions to ask are, does the trial ask an important question? And a trial that doesn't ask an important question is definitely unethical. Is the control group appropriate? And again, that comes to equipoise. Are you comparing with the standard of care? Are the outcome measures, the endpoints, appropriate? Does the report of the study reflect its results? So is it reported well? And do related trials give consistent results? If it's a one-off unusual result, you should have not put a lot of belief in it. Are the outcomes of clinical value and not just statistically significant? And finally, will the results apply to patients you see in your clinics? Because you should recognize that those patients going into clinical trials are highly selected. And there's a reference for you that we wrote about clinical trials some time ago. So a phase 3 randomized controlled trial should compare experimental treatment with what is an appropriate current standard of care. That may vary around the world, and some trials have had variability or allow options for standard care, and that's okay. They should have an appropriate and well-defined primary endpoint or outcome measure. You've got to define that because the trials aren't big enough to look at lots of different measures. They should evaluate toxicity well, and they should be large enough to detect a meaningful difference in the outcome, but not so large that you simply find a trivial distance because you put in so many patients that small differences become significant. So let's talk at first about the control group. Here's a radiation oncology trial that I suspect many of you may be familiar with that came out in 2006 that compared radiotherapy with radiotherapy plus cetuximab for head and neck cancer, and it showed an overall survival difference. The problem with this trial is it had an inappropriate endpoint. It had an inappropriate control group. It was already known that concurrent radiation and cisplatin improved survival, and there was a meta-analysis by Pignon and colleagues that had appeared a few years before this. So treating the control group with radiotherapy alone was not appropriate, and it has since been found in other trials that radiotherapy plus cisplatin is as good as, at least as good survival as radiotherapy plus cetuximab, and surprisingly is less toxic and remains the standard. And here's another trial published much more recently, the PROfound trial in prostate cancer that appeared in this year's, or actually now last year, since it's 2021, New England Journal. And it compared olaparib, which is a DNA repair inhibitor, a PARP inhibitor, with abiraterone after enzalutamide, whichever they had the other as the control group for men with advanced prostate cancer and genetic defects in homologous DNA repair. And it showed, in terms of its primary endpoint, which was imaging-based progression-free survival, and again, that's, I think, not an ideal endpoint. They could easily use survival, but the control arm was highly inappropriate in this trial. We already know that if a patient with prostate cancer has received enzalutamide, his response to abiraterone is going to be very low, and vice versa. And many men in this trial hadn't received standard treatment, such as docetaxel, and you might have done just as well with a drug like carboplatin, which also will inhibit DNA repair. So I think this is a poor trial. What about endpoints or outcome measures? Now, there are actually, whatever type of physician you are, most of you are radiation oncologists, you can be medical oncologists, you can be surgeons, you can be cardiologists. But there are actually only two goals of any new treatment. And those are either to allow the patient to live longer, to improve survival, and or to allow the patient to live better. Those are the two goals of everything we do in medicine. So what happens is that, so they're ultimately, the ultimate endpoints for a phase 3 trial are overall survival and quality of life. Anything else that you use, any other endpoint, should be shown to be a surrogate for overall survival or quality of life. And certainly there are other endpoints that may well be surrogates. If you're a cardiologist treating hypertension, you're not going to look at survival, and you're probably going to look at reduction of blood pressure, which ultimately may improve survival. But you should show that other endpoints are surrogates. And many phase 3 trials have a primary outcome other than overall survival or quality of life. That's true in medical oncology, it's true in radiation oncology. Disease-free survival is often used in adjuvant trials. Progression-free survival is used in trials of systemic therapy for advanced disease, and local control, or some variant, is often used in trials of radiotherapy or surgery. So let's have a look at one of the results, at least for drug treatments, of using surrogate endpoints. So the EMA and the FDA, the registration agencies in Europe and the United States, have accepted many of these endpoints for approving or registering for sale new therapies. But these have not been shown to improve the duration or quality of survival of cancer patients. And this was a review by Davis and colleagues in the BMJ. There was a similar review by Kim and Prasad in JAMA Internal Medicine, looking at FDA approvals. But what they found was that of 48 cancer drugs approved by the EMA, for 68 indications in that 5-year time period of about 10 years ago, improvement in survival was only shown at the time in 35%. The median improvement was less than 3 months, and improved quality of life was only shown in 10%. And even with 5-year follow-up, only half of the drugs which have been approved for cancer have actually been shown to improve either survival or quality of life. So we have a lot of drugs of very questionable benefit. Many assume that the endpoints that I mentioned convey benefit, PFS, disease-free survival, local control, but that's not always supported by evidence. So adding drugs to adjuvant therapy or radiation to the primary site may improve disease-free survival and or local control. Adding drugs to standard treatment of metastatic cancer may well improve progression-free survival, delay progression, and both can lead to marketing approval. But what you have to think about is you might get just as much gain by applying treatment at relapse that might maintain equal survival and avoid adding toxicity and costs from treating all patients at risk, particularly in adjuvant therapy. And progression-free survival, which I'll say more about in a little bit, is a poor surrogate for overall survival. There are very few instances where it's been shown that it's a good surrogate. And quality of life depends on a balance between delaying symptoms of disease, which obviously people like to be told their disease isn't progressing, but the added toxicity of treatment. And all new drugs and radiation add toxicity. So, and that's also subject to bias from informative censoring, and I'll define that in a moment. So here's a question. We know that these new expensive drugs, CDK4/6 inhibitors, which inhibit cell cycle progression, we know that in patients with advanced metastatic breast cancer that they improve progression-free survival. They probably do improve overall survival. Those results are just coming out, but not by very much. And they're not particularly toxic drugs, but they are very expensive drugs. And now we're seeing trials, and the first one was published recently in the New England Journal, the Monarchy trial, showed improved invasive disease-free survival. So this is invasive, the recurrence of invasive disease for women with advanced breast cancer when abemaciclib was used as adjuvant therapy. And those are the curves. Now, it looks impressive if you look to the end of those curves, but of course, the end of the curves, if you look underneath, are defined by incredibly small number of patients. And it's a small effect that is actually shown enlarged in the inset. So is there a statistical benefit? Yes, but you can see that there's very little difference. And of course, the company wants you to add that as standard in terms of adjuvant therapy for hormone receptor positive breast cancer. And I think that would be a great mistake. It would be treating a large number of patients for very, very minimal benefit in an endpoint, disease-free survival, that is not necessarily going to improve survival. And in practice, small improvements in disease-free survival don't usually lead to improved overall survival because you can use the drug in the much smaller number of patients who relapse rather than give it to everyone. And here's an example of informative censoring. So what is informative censoring? Well, people use progression-free survival. And if patients go off study before their disease progress, they're forgotten, they're censored. So this happened in this trial of everolimus, again, for hormone receptor positive breast cancer, added to a steroidal aromatase inhibitor after women had progressed on standard hormone therapy. And it looks a very impressive result, a hazard ratio of 0.43, highly statistical significance. But what is the problem? Well, the problem is that there was early stopping due to serious adverse events. Patients couldn't tolerate it or withdrawn consent in a quarter of the patients on the experimental arm but only 6% in the control arm. And those patients are forgotten. So what you're actually doing here are comparing the 76% of the patients who could tolerate the drug with the 94% of the controls. And you no longer essentially have a randomized controlled trial. We wrote about that recently in Nature Reviews Clinical Oncology. And here's what if instead of looking at time on treatment, where you regard people who can't take the drug as failing, which I think it's, or it is failing them, those are the curves you get, very different from the ones I just showed you, although there is still a small significant benefit. And for survival, there was no difference at all. So you can easily be misled by trials that use progression-free survival, and you should look to see if there is uneven dropout, loss of patients. So what should we call an agent that increases progression-free survival, doesn't affect survival, and doesn't improve quality of life and adds toxicity? Instead of registering it for use, we should call it harmful. So what does PFS really mean? So this is my cynicism coming out. It is a planned flawed study. As long as the companies can get away with PFS for registering their drugs, they will use it. So it's endorsed by the FDA and the EMA, and it leads for profit for sponsor. So different acronyms for PFS. Let's move on and talk a little bit about toxicity. So trials should evaluate toxicity comprehensively. So this is one of my former fellows, Bostian Saruga, who's now in Slovenia, his home. And he reviewed several studies underreporting of harm. One of the things that you will find in clinical trials is that there is great emphasis on the positive outcome. If you improve survival, if you delay local control, much less emphasis on harm, on toxicity. I think that's probably less true of radiation trials than it is of medical trials, but nonetheless, underreporting of harm is a problem. And he looked particularly at targeted agents where the toxicity is often delayed. And patients experience much more toxicity than is recognized by us doctors. So there's substantial underreporting of toxicity. And in fact, what he found was that almost 60% of potentially fatal adverse effects were not in the initial FDA label, and around 40% were never reported in a randomized trial because they're published, before many of these events occur. And toxicity is higher when drugs are given in the clinic than to those selected in trials, a point that I'll return to. And really, we as physicians underestimate what our patients are experiencing. This is some work of Ethan Barsh from New York, who showed by having patient questionnaires, looking at various attributes as patients went through various treatments, and that's shown the rates of toxicity by the brownish line, and that reported by physicians like us by the bluish line. So we are consistently underreporting what our patients feel. And if we go into a room and say, Mrs. Brown, how are you? How are you feeling? There's a great tendency of Mrs. Brown to want to please her doctor, and she will underplay her symptoms, and she may be afraid if she owns up to too many symptoms that the treatment will be stopped. And so these are effects that occur. Statistical significance versus real value of treatment is an important problem. Statistical significance is not the same as clinical significance. Unfortunately, the FDA and the EMA will register drugs on the basis of any trial that shows a difference in an approved outcome with a p-value of less than 0.05. And what that does is stimulate companies to do large trials to detect small differences. So here's an example, a drug called aflibercept. It's a VEGF inhibitor, and you get curves like this for advanced disease with an expensive and toxic drug, and it's approved. And that shouldn't happen. Does the report of the study reflect its results? Well, in reports of phase 3 randomized trials, the primary endpoint should be defined explicitly in the abstract of the paper or presentation. The primary endpoint should reflect benefit. We've talked about that. The concluding sentence of the abstract should relate only to the primary endpoint, and the abstract should include a statement of major toxicity, and that applies to trials for all diseases and for all modalities. And unfortunately, many reports, both in high-level journals and at meetings like ASCO and ESMO, and I'm sure at ASTRO and ESTRO as well, do not meet these simple guidelines. This is another of my former fellows, Paco Virabadillo, who's Mexican but has stayed in Canada. He looked at breast cancer trials of various types, randomized trials, published between 1995 and 2011. And there were 164 trials for breast cancer, randomized trials for breast cancer in that period that had more than 200 patients. And about 2/3 of them were actually negative. So about 1/3 were positive for their primary endpoint. And in the negative trials, it was very common for the concluding statement of the abstract to use secondary endpoints to suggest benefit. For example, a trial is set up to look at survival. Although we didn't see a difference in survival, we did see a better response rate in so-and-so. And that is a common sort of type of bias. 1/3 of the abstracts indicated frequency of grade 3 to 4 toxicity, so that was underreported. And positive result for the primary endpoint was associated with underreporting of toxicity. Now, you could find toxicity in the paper, but let's face it, a lot of us are very busy and we concentrate on the abstract unless it's a paper really in our area. And honorary and ghost authorship was common. Ghost authorship is where you get somebody to write your paper. Honorary authorship is where, usually at the behest of companies, you have a well-known author. And I'm sure many of you have seen the same author on lots of papers. Motzer on kidney cancer, Baselga on breast cancer, etc. And you realize that they can't have been the major player in every trial, and they're parachuted into because they're supposed to lead people to change practice. And there were similar findings in randomized trials for other malignancies in further studies. Ghostwriting. So I recently reviewed ESMO abstracts, being a medical oncologist, and the meeting was held in last September. And one of the things I noted when I just looked at those large randomized trials was that 80% of those reporting pharmaceutical-sponsored phase 3 trials acknowledge writing assistance. What does writing assistance mean? Well, if they couldn't even write their 350-word abstract, it means the somebody employed by the company is writing it, and you can certainly bet that if they wrote the abstract, the company prepared the slides. And obviously, they are going to have a tendency to bias the results in favor of their product. I then reviewed 3 months of publications of trials in the New England, which requires authors to state, and so does the Lancet, who wrote the first draft. And 16 of 21, so again, roughly 80% of reports were drafted by a medical writer. Kudos to the 5 where the authors actually wrote their paper. And while some medical writers might draft unbiased reports, they are employed by or contracted to the sponsor, and there is substantial potential for biased reporting. So do look as to who wrote the paper. With the reporting of randomized trials, editors of journals and reviews should have a checklist to ensure that conclusions are based only on the primary endpoint, comprehensive reporting of toxicity, and authorship is deserved and appropriate. We do not need honorary authors, and we do not need ghostwriters. And there is actually a study which I played a relatively minor part in. It was led by a French group, by Isabelle Boutron, that actually looked at the impact of spin in abstracts of articles reporting the results of randomized trials. So what we did in this study was to select 30 abstracts from the literature, all major cancer randomized trial papers, that we judged were reported with spin or bias. Spin is a political word. Politicians use it all the time to make things look different to what they are. And then we rewrote those abstracts, keeping the data the same, but rewrote them without spin. And then we had 300 oncologists, people who publish and write about cancer, and we sent them at random an abstract with spin and an abstract without spin. And then we assessed their opinion as to the value of the treatment that was being looked at. And what was found was that for abstracts with spin, the experimental treatment was rated to be more beneficial. So we are subject to bias and to spin, and we have difficulty in separating the results of the trial from the bias that is present. Another thing is subset analysis. So clinical trials are usually powered to analyze the whole group, and subgroup analyses can lead to false results because you're going to have statistical artifact. And a good example of that was that when 5-FU and levamisole were first shown to be beneficial as adjuvant treatment for colon cancer, in the Mayo Clinic trial, there was a subgroup analysis that suggested it was more effective for men and older patients. And in the Southwest Oncology Group trial, it was more effective for women and younger patients. And obviously neither of those are true. There is an overall effect, and we're simply looking at statistical variation. And we see this in some recent trials. So here's a trial of an immunotherapy, PD-L1 inhibitor, atezolizumab for used with chemotherapy for triple-negative breast cancer, a large trial. At least they had overall survival as a co-primary endpoint, stratified for PD-L1 expression. And overall, this trial did not see an overall difference in survival. So there's the survival curve, and you can see that there's no statistical difference in overall survival, but then they look at a subgroup analysis for the PD-L1 positive group, and they do find a difference. Is that real? Possibly, but again, one has to be suspicious when you're using a subgroup analysis. Are the outcomes of clinical value as well as statistically significant? So here is a statement by the American Statistical Association about p-values. It's on their website, and it was published 4 or 5 years ago. P-values do not measure the probability that a hypothesis is true. Scientific conclusions and policy decisions should not be based only on a p-value. A p-value doesn't measure the size of an effect or the importance of the result. The more patient, if you have a tiny difference, the more patients you put into a trial, you'll make it look significant. And by itself, a p-value doesn't provide evidence regarding a model or hypothesis. But what do? If you're the editor of the New England Journal or Lancet, getting your paper in there is going to depend on whether you have a p-value of less than 0.05. If you're at EMA or FDA, whether you approve the drug depends on that magical p-value. They are ignoring this statistical effort. And John Ioannidis has written a lot about these false things, and he has this paper, Why Most Published Research Findings Are False. And he simulates this, showing that for most study designs and setting, it is more likely for a research claim to be false than true. Statistics can be misleading. And the important test of validity of a clinical trial should not be the p-value. It should be whether or not the result is reproducible. It's important to have confirmatory trials. And then value. So a statistically significant result doesn't necessarily imply clinical value. And I said consistency is more important. And ESMO and ASCO and the NCCN have scales to assess the magnitude of clinical benefit or value. And sensibly, they emphasize improvement in durational quality of survival. This is the ESMO system. It applies mainly at the moment to drug therapy, but it can apply equally to radiation therapy. And it separates the diseases into whether, the treatments into whether they're potentially curative, that is adjuvant therapy, adjuvant radiotherapy, adjuvant medical therapy, or non-curative. And it rates the outcomes on a scale. And those with A and B for curative, 5 and 4 for non-curative are regarded as of value, of clinical value. And you could easily rate the results of a trial using their schema, which is published. And so one of our residents, Joe Del Paggio, looked at us whether contemporary randomized controlled trials, or trials now published up to 5 years ago, met the ESMO criteria of benefit. And he looked at a large number of trials of breast, lung, colorectal, and pancreas cancer, of which 50% were positive for the primary endpoint. But only 30% of the positive trials met the ESMO threshold for clinical benefit. And only 30% of trials were even designed to detect or exclude differences in outcome that met the ESMO threshold for benefit. Much better for curative intent, and indeed even a small difference that is statistically reliable in patients who are cured is important, but very few of them with palliative intent. So the current situation where new therapies providing marginal benefit in highly selected patients are approved at high price is neither desirable nor sustainable. Consideration of clinical benefit and value that includes quality and consistency of evidence for effectiveness, toxicity, and costs would be welcome. Oh, sorry. And what we need to do is to put pressure on registration agencies to use a criterion of value for approval rather than statistical significance of an outcome measure. But so far, that just has not happened. Okay, the last point about clinical trials. Will the results apply to patients that I see in my clinic? Here's an example of what we call the efficacy effectiveness gap. Efficacy is in a clinical trial, effectiveness in the clinic. So this is another fellow who worked with me from Switzerland, Arnaud Templeton, who did this study. And the TAX 327 trial for prostate cancer, which I chaired, established the role of docetaxel for men with castrate-resistant prostate cancer. And in that trial, there were 335 patients who were in the arm that got docetaxel. The median survival was 19 months, and 3% of them had septic neutropenia. So Arnaud looked at what we did in routine practice at Princess Margaret when we gave exactly the same treatment. And what you see is that in routine practice, our median survival was 13 months, highly different to what we got in the trial, and almost 10% had septic neutropenia. If we looked at the patients we put in other trials, we did just as well. The difference is not the quality of treatment, the difference is in selection of patients that go on a trial being quite different to the ones that you see in your clinic. In a trial, you don't put in people with low performance status, with comorbidity. And this is where population-based observational research is important. This is Chris Booth, with whom I worked with a lot, and some of you may know him because both of us participate in the Credo workshops over the last few years run by Priya and Pramesh at Tata. So randomized controlled trials have the advantage of giving you a precise measure of efficacy under ideal conditions. Only by randomization do you actually ensure that the patients you are comparing with different treatments are similar. But the problem is that because the patients are selected, they have poor measures of effectiveness, they give limited information on toxicity, they're published too early, and you don't have all the other diseases and comorbidities that contribute to that, and their application to clinical practice can therefore be limited. The problem with population-based studies, if you see a difference comparing, say, patients in a registry before and after, or patients in a registry getting or not getting a treatment, it's difficult to eliminate bias and confounders. But they can estimate the effectiveness in the general population, they can assess toxicity under real-life conditions, and they can evaluate the uptake of treatment in a general population. So we wrote about recently, this has actually just come out, this efficacy effectiveness gap. And we should be telling patients about this. When we go and approach patients and estimate how well they'll do, we often look at the result of a trial. But we need to adjust that because patients don't do as well as in trials. They're younger in trials and they're selected. So I've already defined efficacy and effectiveness. And here's an example of a study done by Chris Booth and his colleagues. We have a very good cancer registry in Ontario. The 5-year survival after radical cystectomy for muscle-invasive bladder cancer in clinical trials, a selected case series, is about 50%. In the Ontario Cancer Registry, based on 3,000 people, it's about 30%. Does that mean our urologists are poorer than those who are publishing? No, I don't think it does. It simply means that those going into clinical trials are selected as those who have better outcome. Okay, so that's the end of the lecture, and I think I'll stop now. It may challenge me taking the screen backwards and forwards, but I do have some radiotherapy trials that we can discuss. But why don't I stop sharing and first ask if you have questions? Open for questions.
Thank you, sir, for this excellent presentation. Yeah, we do have a few questions. Shall I ask them, or can you see the chat box, sir?
Yes, okay, let me just put it on. Okay, the first one says, sure. Okay, the first question from Santam Chakraborty is, do you think our insistence on abstracts of 300 words and word-limited manuscripts do a disservice to science? I think my answer to that is no. I do think we should be more selective in papers, but you know, people are busy, and writing a paper that is lengthy really defeats the purpose of having it read. So there is an art in writing things succinctly. There is a quotation, it's been ascribed to various people. I think Benjamin Disraeli was one, an old British prime minister from the 1800s. And he said, I wanted to write you a short letter, but I didn't have time, so I wrote you a long one. And that then comes down to saying, you really have to work to say what you want to say very briefly and succinctly. But we do need a summary of the results. And the guideline for the abstract is simple. It should define the primary endpoint, the number of patients. And we did have a paper at one time on what an abstract could contain and how many abstracts failed. It should only look at the primary endpoint, simple statement of toxicity. You can do that in 300 words or 250 or whatever it is. And then most papers have a limit of about 3,000 words. And again, I think that does not do a disservice for science. I think you can state the important results directly. You should have the caveats, you should have the criticism and the discussion. And nowadays, you can always put more detailed things online. And in fact, most of the good journals require you to put the protocol for your trial online. So if you really want to go into the details of what people have done, that's possible. So I think the answer to that question is no. If reporting of, so this is Santam Chakraborty again, if reporting of toxicity in a randomized trial is inadequate, how can we say that outside of randomized trials, toxicity will be reported more completely? We can't. We still probably underestimate toxicity, but there is a requirement, or at least an advisory, that when you are treating drugs that have been recently approved, and if you see toxicity, it is important to notify the company, if it's a drug, and the FDA. Now, does that happen completely? No, but it does happen because some of the research we've done on reporting of effects looks serially at the FDA website. And some of the targeted agents that we were in particular looking at, but it would apply to other therapies, show that with time, you start to see more and more toxicity. And there have actually been examples, at least one example, I think two, where a drug has been approved and the randomized trial published, and with time, toxicity has been reported. And if it's severe or fatal toxicity, the drug has been withdrawn. So the answer to your question is we can't assure that toxicity is complete. But if it's severe, if you have a patient who dies of or is severe side effect, you are likely to notify people about that. So it's better than nothing, but we can't be sure. Okay, do I think that most studies of novel drug methods should be required to report the number needed to treat and the number needed to harm figures as well? And what's your opinion on simultaneous Bayesian analysis reporting of trials as more comprehensive assessment with conditionalities modeled into it? It's a very good question, and I think the answer is yes. It would be very good to report the number needed to treat and number needed to harm. Particularly, one of the areas that has done this is in the PSA screening trials. As you can see by my white hair, I am a man of a certain age, and I have consistently refused to have PSA screening. And when you look at the results of how many patients you need to treat in order to save one life from prostate cancer, even if you save any lives because there is a harm from that, the number needed to screen is very large. And I think too, in treatment trials, the number needed to treat in order to benefit is a good figure. And for example, in the adjuvant chemotherapy with a CDK4/6 inhibitor that I showed you, you'd need to treat a large number of women if that small difference is sustained as more people are followed for longer. You need to treat a large number of women to save, well, you don't even know you save a life, but even to prevent progression. And I do think Bayesian analysis should be used more often. Bayesian analysis is where you are continually looking at your data and revising what the design of your trial. That's what's been used in the trials to bring the vaccines for COVID forward. If we hadn't had Bayesian analysis, if we hadn't had ongoing looking at that data, then I think we would not have done so quickly. Now, there are problems. I'm not a statistician, but of course, the more you look at the data, you can stop on an arbitrary statistical high, but there are ways of correcting for that. And yes, I think in the future, Bayesian analysis is going to be used much, much more commonly than simply setting at the outset a difference that you want to show either does exist statistically or can be ruled out. Saja, wait a minute. I think I just lost. Wait a minute. I lost something here. The chat disappeared. It was somebody who'd had a personal experience, but I missed it. It went off my chat box. So let's see if I can get. No, I can't get that down. I got something here, something about less than 0.5 centimeters. The results between radiation observation was inconclusive and hence not published in a conference textbook. Well, it's unethical not to publish research. I don't know the first part of that question because it went off my chat. When you undertake a clinical trial, you're entering into a contract with your patients. And if you don't publish it, then people can do the same thing again. And if you don't publish it, you're breaking that contract. So if you get a negative result, it's equally important to publish. Now, realistically, you're not going to publish many negative results in the New England Journal or high-level journals. But if your trial is well done, you can publish it. And fortunately, with PubMed and others, people will find it. So that's I think, very important to publish it and to present it. Galaxy M30, whoever Galaxy M30 is, much of the evidence in head and neck cancer trials have a heterogeneous group of patients, and the evidence comes from subgroup analysis. How do we judge these data for clinical appropriateness? Well, I think, first of all, you have to be a little bit skeptical about, or very skeptical about a single result. One of the things that, meta-analyses and other combined analyses can do, there's nothing wrong with looking at subgroup analyses as a way of forming hypotheses. So if you look at a subgroup analysis and then do a trial for a site, say hypopharyngeal cancer or whatever, that's okay. And if you do subgroup analyses of several large trials and find a consistent result, then I think your data are much more believable. But I think you have to look carefully at every type of subgroup analysis that you do. Thank you for the comments about my lecture. And then we've got Colin McHayden. Now you sound more like a Scotsman than you do to be coming from India. Do you consider multiplicity of testing across indications to be a problem? In particular, when a targeted agent is added to standard of care in multiple settings of diseases, often without credible rationale for doing so. I'm particularly thinking of agents like bevacizumab, PARP inhibitors that have been tested in nearly every possible disease setting. Well, I think basically it's not wrong to do trials if there is at least some phase 2 data to suggest some benefit. But I don't think you can put those trials together. I mean, bevacizumab back 10 years ago was the most profitable drug on the market. As I remember, it raised $5 billion for Roche, I think it is, in 2011. Personally, I think we could well do without bevacizumab. I mean, where it works at all, it does pretty minimal benefit. And so, looking at it in multiple ways, I did trials in breast cancer and lung cancer. It has an effect on the tumor. You have a small difference in progression-free survival with added toxicity, and in most sites, no difference in overall survival. So I think you have to look at the individual trials, and we do know that results are context dependent. We do know, for example, for immunotherapy, that drugs like pembrolizumab and nivolumab can improve survival, do improve survival in diseases like melanoma, lung cancer, kidney cancer, but they don't do so in a lot of other diseases. PARP inhibitors, where you have inhibition of DNA repair, if you have diseases, and I showed you the profound study in prostate cancer, there was another one in pancreatic cancer, and there it's very questionable. I mean, in neither of those situations was it shown to improve survival. The drug is extremely expensive, and there is toxicity. They're not the most toxic drugs, but there is toxicity. And so I think you have to look at the individual trials. Multiplicity also means something else. It's where you do multiple p-values, and you have to be careful of that, because obviously, if you do a number of p-values, when you can see things that 1 in 20 p-values will less than 0.05 by chance alone. Irish, says Colm. Oh yes, Colm. It's not Colin, it's Colm. I do beg your pardon, Colm. I would have known that. I think I've answered all the questions there. Have anybody else got any questions? You can say them out loud if you want.
All right. Thank you, Professor Ian, for your excellent lecture and the valuable discussion. I have a concern which will then lead on to a question. This is specifically related to radiation trials for SRS of brain metastasis versus whole brain RT, with or without combined and or individually. Now, one of the major issues which I have with these trials being reported is that they usually now focus on more on quality of life issues. And even if we consider the quality of life questionnaires and issues to be validated and valuable, the question then is, should it become the primary endpoint? And if yes, under what circumstances can we then use the numbers needed to treat and harm concept, because that does not really translate well to a quality of life kind of subjective scenario, does it? So I would like to have your thoughts about this, please.
Okay, so I do teach about quality of life. I think one of the things, first of all, I think quality of life, if done properly, is a perfectly valid endpoint. And to people with advanced symptomatic cancer, be it from brain metastases or other symptoms, quality of life is as important, and to some people more important, than overall survival. So quality of life is important. The second point I would make is that quality of life in trials has been done extremely badly. And yes, you can use a validated instrument like the EORTC QLQC30, and there are specific types or variants of that, or the FACT. I'm sure there are instruments for CNS toxicity, etc. The problem is that many trials try to look at what they call mean quality of life. So they take a group of baseline, they have the patients fill a quality of life questionnaire, and they do the same, say, 3 months later, and ask if it's changed. And that is nonsense. You can't talk about mean quality of life. We know that with treatment, some patients will get worse, some will get better. The analogy would be measuring tumor response by measuring the average tumor size over a group of people, and of course then looking at whether the mean changed. We don't do that. Instead, we look at the people as individuals, and we ask the question, how many had a predetermined improvement, and how many had a predetermined decrease in their in tumor size in that case. And we should do the same for quality of life. So when we did our first trial of chemotherapy in prostate cancer, we used pain, and we asked what proportion of patients starting treatment had a predefined clinically important improvement in pain. And I think when you look at the brain metastasis example, you should do the same. If you say, you use a quality of life score that relates to CNS metastases and their symptoms, and you ask the question, you give people the questionnaire, you give them the treatment, and serially afterwards, every month or so, you give the patients the questionnaire, and you ask what proportion of those patients with brain metastases had improvement in the relevant endpoint of quality of life. And you have to define one to avoid that multiple assessments. And if you do it that way, you can actually do number needed to treat. The number needed to treat, how many you need to treat to get a predefined improvement in this quality of life scale, the number needed to harm, how many are treated with a predefined harm from that treatment. So I do support quality of life as a primary endpoint when appropriate, and I do think it's appropriate when you're treating brain metastases. The answer to your question is, well, I hope that's pretty much an answer. But it has to be done properly, and generally it hasn't been done very well. I don't have at my fingertips what people did in those assessments to answer how it was done, but it can be done.
Thank you. So as a follow-up, so it should not only be predefined endpoints at a predefined number of people, but it probably also should be at a predefined time endpoint, because the whole concept of people dying would decrease the numbers needed to answer the questionnaire itself, which might then lead to false results. Is that okay? Is that correct?
I think the way that I prefer to do this, I mean, all your patients with brain metastases are going to die. So the way that I would do this is that I would measure that quality of scale at monthly intervals. And if you do that, you can define the proportion of patients who first have a quality of life improvement. And typically you would require that to last for at least a month. So on 2 successive evaluations, an improvement in the score. And usually anything more than a 10 or 15% improvement in a normalized scale is clinically important. And you can also define how long it lasts. So I wouldn't necessarily do it at a fixed time, because some people may have rapid improvement, some may have delayed improvement. And patients, once they die, they're obviously not included. That your denominator is the patient starting treatment. So once they die, it doesn't really affect that. It's the proportion of those who started treatment who have an improvement in quality of life.
Thank you so much.
Other questions? Do you want me to try and show, I don't know what your time scale is, do you want me to try and show the trials that I collected?
Yes,
I
sir.
have about 5 radiation trials, and I can try and show these and you can comment on them.
Yes, sir.
Okay. So here's the first one. And I think this is fairly easy. So there are 2 recent studies that randomized men with high-risk prostate cancer who had a radical prostatectomy to adjuvant versus salvage radiotherapy. And the background to this were a couple of trials, one American, one European, I think, that suggested that adjuvant radiotherapy should be given and one did not. And so these 2 trials, one was done in Australia, one in Europe. The control group was adjuvant radiation therapy, which was thought to be the standard. The primary endpoint was freedom from biochemical recurrence or event-free survival. You could argue about that, but you are trying to prevent recurrence. Toxicity was obviously less if you didn't give immediate adjuvant radiotherapy. Events are quite rare. Then the primary outcome was similar in the randomized group. And neither trial met its pre-specified statistical criteria for non-inferiority, but there was no trend for patients with adjuvant radiotherapy to do better. And so the question is, do you change practice? So escape from that if I can. Oh, I don't know if I can. So what do you think of those?
So, Prof, both of them were non-inferiority trials with the adjuvant as the control.
They were non-inferiority trials. One of the problems of non-inferiority trials is they set very tight statistical limits. And basically, to get to satisfy that, you often need a trial of about 2,000 patients, whereas these had about 400 patients. On the other hand, both of them showed no trend to improvement with adjuvant therapy. And there is, as you may know, the radicals trial, which is larger, which is consistent with that. It's not published yet, to my knowledge. So should you change practice? Now, we've written recently, we have a commentary coming out in JCO, Journal of Clinical Oncology, on a concept called near equivalence. And it makes the case that very often we don't do many large enough non-inferiority trials to show statistically that there is no difference. However, if we have consistent trials showing that the less toxic, less costly regimen is not obviously leading to deficit, my view is that we should accept that. So I personally,
would definitely discuss. I would definitely discuss with my patients.
Yeah, I think I would discuss it too. I mean, I'm not a radiation oncologist, but I think our standard should be not to give radiation as an adjuvant for people undergoing surgery for high-risk disease, but to use it for patients who relapse.
Agree.
Any other comments? Okay, let's go to the next one. So as I said, it's supported by the radicals, which was presented by Chris Parker at ESMO. Okay, here's a sarcoma trial. Pre-op radiotherapy plus surgery, and I just drew these from a random look at recent trials, large randomized trials on PubMed, or relatively large. EORTC trial for a relatively rare disease, retroperitoneal sarcoma, 266 patients randomized to surgery plus or minus pre-op radiation therapy. And the primary endpoint was abdominal recurrence-free survival. And again, you could argue about the endpoint, whether it should have been overall survival. So the median abdominal recurrence-free survival was 4.5 years, with a wide confidence interval for surgery with pre-op radiation therapy, and 5 years with, again, a wide interval with surgery alone. Clearly, those are not significantly different. And radiotherapy to the abdomen adds toxicity, as you all well know. And the conclusion of this was pre-op radiation therapy, which is standard of care for limb sarcoma, should not be considered the standard of care. Obviously, this is another trial that does not satisfy non-inferiority. The statistical margins are wide here. So what would you do in the face of this result?
So if I may answer this question, Prof, we have actually changed our practice. We were proposing neoadjuvant radiotherapy to a sarcoma, but in face of this result, we have stopped offering to the patients. And currently, we have a very limited role of radiation, I believe, in retroperitoneal sarcomas only for those patients where you have a positive margin, or you have a recurrence, or where the surgeon feels he cannot go back and resect it if required.
Okay, anybody else want to comment?
Assuming that this was designed as a superiority trial, this is an assumption. I have not actually read this trial, but assuming that it was designed as a superiority trial, not finding certain things does not necessarily imply non-inferiority or even equivalence. So
this was actually designed as a superiority trial.
Yeah, assuming that it was designed as a superiority trial, not finding a particular effect size difference, statistically speaking, with 250 odd patients, I'm not sure whether this would be considered clinically equivalent or non-inferior. That would need a separate trial unto itself. I would actually like to know the numbers needed to harm in the radiotherapy arm for me to actually make a clinical decision. If radiotherapy added a lot of grade 3 plus toxicity, or it impacted adversely on surgical recovery, I may not institute that in the preoperative radiotherapy as a standard. However, if there's not much difference, then it's up for discussion, I believe. What do you think, Professor?
I think basically, I mean, obviously there is no proof that pre-op radiation therapy does harm people. With a larger trial, you could have seen a difference in survival. But I think you have to go on the best evidence that you have available. And to my way of thinking, I really do believe that you have the best evidence is there is no difference, and that clearly there is harm of giving the treatment. So in the absence of further evidence in this somewhat rare tumor, my own bias is that I would not give pre-op radiotherapy. That is how I would advise patients. I seem to, I'm talking to you, but I've lost the pictures on my Zoom. I'm not sure if I can get my screen back for you. Let's try. Can you see the screen?
Yeah.
Yes, sir.
Okay. So basically, it's imperfect evidence, but really, I think the fallback position is first do no harm, and I think that given this result, I would agree with their conclusion that pre-op RT should not be considered standard of care. Okay, let's move on. Synchronous versus sequential chemoradiotherapy in patients with breast cancer. So this is a large trial. It's 2,300 women essentially randomized to radiation therapy to the breast or chest wall, synchronous with or after radiation therapy. Synchronous with after chemotherapy. I'm sorry, that should be. The primary endpoint was local recurrence. 10-year recurrence rates were 4.6% if you gave the radiation together with chemotherapy, and 7% if you gave it after. So low recurrence, but there's about 2.5% more recurrence if you delayed radiation therapy. The hazard ratio was 0.62 and the p-value was significant. There are more skin reactions with synchronous therapy, so there is harm, and there's some increase in late telangiectasia, although it was relatively uncommon. The disease-free survival and overall survival curves are superimposable, and the 10-year disease recurrence rates were essentially identical. So should you give your radiation during or after adjuvant chemotherapy? Comments?
I would request someone else to give a comment also.
Don't be shy.
I think we should give chemotherapy first so as to give a systemic control and radiotherapy later.
Well, the trial suggests that systemic control is actually not lost here. I mean, I think delaying chemotherapy almost certainly would do that. I agree with you. I think that although you have a slight difference in recurrence rate favoring the synchronous, you do have more toxicity. And if you have local recurrence, particularly at a low rate, that is recoverable by treatment later. So my view is you've got the same survival, you've got more toxicity with synchronous treatment, and therefore I think what we were doing, and I think still are doing at Princess Margaret, is we tend to give radiotherapy after chemotherapy. But you know, it's a debatable point. Certainly you shouldn't delay chemotherapy because people die of systemic disease rather than local disease. Any other comments?
Sir, if I can make a comment.
Yes.
Since these were all early breast cancer, so probably most of the patients may have undergone a breast conservation. In such a setting, local recurrence is an important endpoint because if they end up having a recurrence, they end up undergoing mastectomy.
That's true.
So the primary aim of conserving the breast is lost. So if there is significantly, I mean, there is almost a 3%, 2.5 to 3% difference in local recurrences. I need to see how many of them were post breast conservation surgeries. So there probably is a rationale to use RT along with chemotherapy.
Approximately half had mastectomy and half had breast conservation.
Yeah, but I can't remember of the recurrences in which group they were. So
they were more or less same, Professor. There was
Okay.
no indication of an interaction with the type of surgery that was there.
Yeah. I mean, again, you can make that case, but and I don't think it's wrong. There's no right or wrong answer here. But on the other hand, the overall survival was the same. And if you're talking, you know, of 1 in 50 or 1 in 40 women having to undergo mastectomy because she had a recurrence in the breast, I mean, it's an effect, but it still doesn't impact on survival. And obviously the number that would have to undergo mastectomy is quite small. and is it worth the immediate treatment, the potentially increased toxicity. Now, there wasn't any increased chemotherapy toxicity, which is important, and there wasn't a requirement to reduce dose. So I think it's an open question, but my practice when I was treating breast cancer is to give the chemotherapy first and immediately after and of course this is decided with my radiation oncology colleagues, was to give radiation immediately after chemotherapy. So that's in general what we did. I don't think this trial would make me change that.
Can I ask a question to Dr. Sayan?
Yes.
So yeah, what kind of chemotherapy are you trying to give with radiation in synchronous setting? Which chemotherapy are you
Well,
prescribing?
they divided it up into those that had anthracyclines and those that did not. But there was some variability in the chemotherapy that was given. Now, in my institution, for those that have more aggressive breast cancer, we would either use 2 weekly chemotherapy with a taxane, or we would use FEC-D, so anthracycline followed by a taxane, and we give radiotherapy afterwards.
So, Professor,
And
with that
Professor,
information, I would like to know what happened to the cardiac
yeah,
late toxicity,
same.
especially in women with left breast cancer, side breast cancer, assuming that they were treated with hypofractionated radiation and anthracyclines. I would be interested in knowing that.
Yeah, clearly, we know with modern radiotherapy techniques, the disease to the heart, even left-sided, is much lower. I don't have figures to tell you about that. I can tell you that it was a rare complication, but I don't have the figures. And of course, if you, in addition, have HER2-positive breast cancer, where they're also getting trastuzumab, there's further risk of that. But I don't have figures for you.
Thank you.
All right, let's go on. Prostate PSMA PET CT. So this is an Australian trial by Michael Hoffman and colleagues. I know Michael. So 300 men randomized to conventional imaging or PSMA PET CT. And then they looked at 6 months with those who had surgery, histopathology. Patients could have surgery or radiotherapy for prostate cancer, histopathology, imaging, and PSA level at 6 months, which revealed that 30% of them, about 90 of the men, had pelvic nodal or distant metastases. Those would have been present at the time of the imaging. And their primary endpoint was accuracy, the area under the receiver operating characteristics curve, for diagnosis of pelvic or distal metastases. And the accuracy was 92% for PET based on that follow-up assessment versus only 65% for conventional imaging, which included CT or MRI. So there was greater sensitivity and specificity for PET imaging, and there was more change in management with PET. So 28% of patients had change in either abandoning curative therapy, so not giving surgery or radical radiotherapy, or in changing the surgical operative field or the radiation field, versus 15% with conventional imaging. There's no data on long-term outcomes. So should PSMA PET replace conventional imaging? Who wants to comment on that?
Prof, I would like to know, in this study, actually the accuracy was assessed based upon the follow-up recurrence pattern. Or no, it was,
well, of course it was for those who had surgery. If they found a pelvic nose at surgery, then you knew they were present. Other than that, some patients had biopsy, but imaging 6 months later that showed the presence of nodal or metastatic disease, or those with rising PSA. So it's not perfect in terms of how they assessed accuracy. You could argue that this gold standard isn't very gold, but it's probably the best that they could do.
And there is no data on toxicity.
There's essentially no toxicity from PSMA PET. These are comparing two
No,
imaging.
but when the people underwent conventional imaging, obviously they had toxicity from the therapy, and when the patient had PET PSMA, they had toxicity from the therapy.
Yeah. So
That data is not there.
no, I don't think so. I mean,
So I don't
it
think we
would
have
only
adequate
be,
information to change the diagnostic paradigm here.
yeah, it would only, the toxicity would depend on the treatment they subsequently received, and there were some changes, but you can see that that's going to be a relatively small number. So I don't think you'd get meaningful differences in, well, neither outcome in positive and negative outcomes. But
Professor, sorry,
you do prevent some patients who would not benefit from having radical treatment.
Professor, I think this should be a starting point to conduct a randomized trial with the primary endpoint being probably overall survival or some kind of a surrogate like uh, rec- biochemical recurrence-free survival. Because although the accuracy is definitely better, even the confidence intervals are not crossing, but we don't really know whether the change in management was blinded and or randomized, because I don't think that they would have randomized that. So we cannot really take that as a good surrogate for actual effectiveness of so-called change in therapy in either direction. So perhaps this would be a good point to do a randomized trial, another one. What do you suggest?
I think that's great, actually, and they will follow up these patients. It's too small, probably, to see a difference, but I think it's generally true that, you know, when we introduce a new treatment, be it surgery, radiation, or chemotherapy, or systemic therapy, we ask for outcomes, and they should ultimately, as I said in the lecture, be related to survival or its quality. Yet, when we introduce new imaging devices or other, you know, technologies related to that, we just accept them on the basis of whether, you know, they give us, as you say here, better accuracy, but we don't actually know if it improves outcome. And obviously, PSMA PET CT is very expensive. I mean, the machines are very expensive. Everybody's got CT available. Most have MRI. Clearly, not everybody has PET. And even at Princess Margaret, we certainly have PET machines, but we have to ration their use. So I think what you say is a very good comment, that really we should be judging new imaging and other diagnostic tests as to whether they ultimately improve outcome. So I think that's a very valid comment.
Professor, can I ask you a question as a follow on this? Is that all right?
Yeah,
So
please.
my question is actually going to be following from this PSMA PET CT for prostate onto the latest FIGO guidelines for the staging guidelines for CS cervix, cancer of cervix, in which they have actually introduced a 3C1 and 3C2, wherein pelvic lymph nodes versus parotid lymph nodes. And based on this, now AJCC and I think, if I'm not wrong, NCC and a couple of other guidelines suggest that PET CT should be the standard of care as far as imaging is concerned, because PET CT is more accurate for parotid lymph node than either CT scan or MRIs. Now, I'm not sure whether that is actually true, because survival or local regional control or anything has actually ever been assessed in any randomized manner. What are your thoughts about that?
Well, I think it's the same comment to the one we just discussed. I mean, yes, you can show that PET imaging may improve diagnostic accuracy, but does it make a difference is what you're asking. And I think ultimately one should do. And, you know, if we just keep adding, just the same as adding new and expensive drugs that don't do very much is bad, adding new and expensive imaging, admittedly, it will become less expensive in time, but adding it where it doesn't make a difference, is that the best way to spend our healthcare dollars? I mean,
Hmm.
every time we put in a a PET CT machine, I don't know how much they cost, but they're probably $1 million US. you know, every time you put in that, you're spending $1 million on a PET CT that you could have spent on something different. And I think we have to ask those questions in a cost-effective way. So if it actually improves substantially the outcome, then yes, maybe that's a good way of spending your money. But if they don't, if you simply get better images without improving the survival of patients, there may well be better ways of spending money than healthcare dollars on a PET CT. So I think that's the way the questions need to be asked. And I fully support your concept that you need to do trials to answer those questions.
Thank you, sir.
Okay, shall we move on? Okay. Sequencing of androgen deprivation therapy with external beam radiotherapy in localized prostate cancer. So this was a trial in which 432 men were randomized to have 6 months of ADT, either starting 4 months before radiation and continuing through the radiation, or starting with radiation and continuing for 4 months after. The primary endpoint was biochemical relapse-free survival, i.e. how long it is before your PSA starts going up. And again, you could argue with that. And the 10-year biochemical relapse-free survival favored starting the androgen deprivation therapy with radiation and continuing for 4 months after, although it wasn't significant. And there was no significant difference in survival. The conclusion were both are reasonable options for standard of care. The curve on the right shows the biochemical relapse-free survival. The upper curve is for starting the ADT with radiation, and the lower curve, blue curve, is for starting it before. So what do you think of this trial?
At the outset, I would definitely need toxicity data to make some kind of an analysis assessment between the two.
Yeah, I don't think there was much difference in toxicity. I mean, the toxicity of ADT is, as you usually find, you know, with your decreasing androgen, so you can get some anemia. You can have bone loss, and you should put patients on vitamin D and calcium. But I don't think there was major differences in toxicity. What about other trials that have gone before it? As I recall, the EORTC trial had, and there have been several trials, but the trials by Boller and colleagues used androgen deprivation therapy for 2 years. And there was a trial of 2 years versus 6 months showing that the shorter time of radiation was actually not as good in terms of survival as 2 years. So I wonder with this trial about whether the control group was appropriate and whether giving this short course is appropriate.
Prof, practically there is another advantage that we gain from giving neoadjuvant for around 3 months or 4 months, that we get some shrinkage in the prostate gland also. It improves the dosimetry. And we, of course, have a slightly better time scheduling these patients also.
Yeah, but you didn't change the outcome. And when you do your radiation planning, I think you usually plan on the original disease, even though you may have shrinkage. Correct me if I'm wrong.
It's not absolute. Means I wouldn't take that part of the prostate which is completely inside the rectum after neoadjuvant.
Yeah. I mean, it isn't showing big differences with either, and there probably are little or no differences, but there is a trend for, you know, I think it is important to use it synchronously in the animal models that show it improves the effects of radiation. But I wonder about whether or not, you know, it was used for long enough. All right, I don't know, there's one more, I think. Hyperfractionated breast radiotherapy for 1 week versus 3 weeks. This is a very large trial, 4,000 patients, randomized to what might be considered standard of 15 fractions over 3 weeks, 40 gray versus 27 gray or 26 gray in 5 to the breast and chest wall. Again, some patients had mastectomy, some had breast conserving surgery. Primary endpoint, ipsilateral breast tumor relapse. So obviously what you're trying to prevent. And those were very low, all around 2.1, 1.8, and 1.4%. There were higher normal tissue effects in 27 gray and not 26 gray and 5 fractions compared with the standard 3 weeks. And they concluded that 26 gray and 5 fractions is non-inferior to 40 gray and 15. And clearly, if you can treat more quickly, you spare patients coming to the hospital, it should be cheaper, and seems that might be the new standard. So what do you think? And why do you think of having a 3-arm trial? I mean, was it sensible to have both 26 and 27 gray and 5 fractions?
Exactly.
Is that really a difference that's going to be likely to show?
It was actually, Prof, it was not actually designed to show a difference in efficacy. It was basically because we had limited knowledge about the radiobiology of breast cancer. And luckily, we are actually doing a trial which is quite similar. This is the hypoadjuvant trial where we are testing 26 in 5 against 14, 15 in our population in India. And
Good.
our logic and rationale behind that study was primarily the fact that the ipsilateral breast tumor recurrence in this study was quite low because this was primarily a screen detected early breast cancer population. That said, this fractionation practice actually has become more or less standard of care in UK, I believe, after this recent COVID epidemic.
It won't be in the States because they charge by the fraction.
Yes,
so
that is a different thing altogether. But that is a completely. But the design, Professor Yarnold, who was one of the sort of investigators in this study, also helped with our hypoadjuvant study design.
Yeah, I know him.
Yeah,
and David Bloomfield, who was an author, was a fellow with me.
Yes.
My thought was the 26. I mean, I think the trial is very valid, but I think the 26 versus 27, yes, you may not have known exactly, how to use those equations to get, similar biological effect. That struck me as a trial that was designed by a committee, and half of the committee probably wanted 26 and half wanted 27, so they put them both in. But that strikes me as a bit of nonsense.
Prof, actually, it was designed for the fact that the normal tissue effects were not well known.
Well, I agree with you, but I still don't think
so, for example, that's how they showed that 27. Actually, there is a suggestion that when you are fractionating it for 5 days instead of 3 weeks, the alpha beta ratio or the fraction size sensitivity of the breast is probably slightly different, which is why 26 actually came out to be isotoxic as compared to 40, not 27. However, the number of events is very small because the total number of patients, as I was mentioning in my talk also, who had a grade 2+ event is like 10% or so.
Yeah.
And the toxicity event we are talking about is induration of the breast, not like serious toxicity or anything like that, if I may say it like that.
Yeah. Okay, any other comments? That's it. So that's the end of all I have for you. If any of you have any other questions, feel free to ask. If you want to ask me any questions, then I'll have a look at the chat in a moment. But if you can put more questions there. If after we finish, any of you want to ask me questions, you can send them to me by email. It's Ian.Tannock, my name, at UHN, which stands for University Health Network.ca for Canada. Well, let me look at the questions. Yeah, in practice, PSMA. Cost of PET CT may get offset by cost saving by avoiding more radical treatment. That's a very good thought. I mean, it depends. If you've already got a machine that's not overused, I mean, I do remember teaching your residents a few years ago at the Tata, where I've been a few times, and this was a case of metastatic disease, and I asked the residents what they would do, and they said we get a PET CT, and I said, what would you do if it was positive? And they said X. What would you do if it's negative? They said X, the same. And I said, well, why would you do the PET CT if you're not going to change treatment? But it could change outcomes, and that's true. How do you define utility? As accuracy, as a very soft endpoint, and overall survival? No proof. I agree with all of that. Utility is a different word. Utility is used to judge quality of life. When you talk about quality adjusted survival, you can use a utility factor. But in terms of accuracy, it's only accuracy of the image to show what's there. It does not mean that improving accuracy is necessarily going to improve survival, as you have said. Yeah, comments on health technology assessment factored in clinical trials for ISA is incremental cost-effective ratio. I think that is extremely important. I mean, India is obviously a country with a huge spread in terms of wealth and poverty, but it's in general a much poorer country than Canada. But even in Canada, which is a high-income country, there have to be limitations on what we spend on healthcare. Otherwise, we won't have any money left over to send our children to school or university and things like that. So it's extremely important. Any other questions before we finish? If not, it's been great talking to you. I don't know when the next Credo meeting will be. If Priya still wants me to come, I will come happily. But it certainly won't be in the first part of 2021 with COVID still rampant. But I do hope to be coming back to India before too long. I've been there quite a number of times. And I always enjoy talking with you younger people. I'm quite impressed with the level of knowledge and skill of Indian physicians, at least with the people that I've met in major centers in Mumbai and Delhi and Hyderabad I've been, and one or two other places. Take care, everybody, and stay safe and well.
Thank you, Prof.
sir.
That was an excellent talk.
Thank you, sir.
Thank you, Professor.
You're welcome. Bye-bye.
Goodbye. So I think that's it for today. So goodbye and good night.